To learn how a Medicaid health plan uses innovative strategies to engage their members, we'll now hear from Merrill Friedman, Senior Director of the Disability Policy Engagement Team and Stakeholder Advocacy Strategy for Anthem. Merrill?
Great, thanks, Catherine. Good afternoon, everyone. So I appreciate the opportunity to be here today and talk through a couple of key issues focusing a lot around the social determinants of health and supporting people. So the obligatory, snapshot here about Anthem, is the fact that we do partner with 20 state Medicaid agencies to provide coverage for about over 6 million Medicaid members. And I'm sure everybody on the webinar today is aware that there has just been a strong trajectory to more states looking to engage managed care arrangements to support adults with disabilities, including mental health and substance use disorders, older adults, children with specialized health care and service needs. So that basically turns into what we do is focus and spend a lot of our time in our communities bringing health care and services and support to our members and their families. So I think here, is really just the crux of all of this, is really to work to create and support a system of care and services that focuses on social determinants of health. We have really found that healthcare is truly about more than traditional healthcare services. When we talk about people with disabilities, older adults, people who have been formerly incarcerated or justice involved, they're not patients a lot of times. They're people who need services and support and want to be integrated and included in their communities. So figure up to 40% of the health outcomes are driven by social and economic factors, and in Medicaid members, these factors are even more pronounced. People want a place to live, make sense, they want to work and contribute to their communities, and they need food. They need healthy and nutritional food, and they need, that consistently to have access to it. It needs to be affordable as well. So in doing so, we provide connections through better care coordination that connects our members to the services and supports in the community, whether or not we pay for those services, and knowing how to create the seamless web of support to reduce disparities. And if you don't have, a place to live, it's much more difficult to get a job. And if you don't have a job, you can't pay for the things that support you and your family. And most people identify, through employment as that, kind of self-worth and that value of contributing. And then most people would say, if there's no food, it's small children. We know that it has a positive impact on brain development. We know that we all get hungry. When we're hungry, we're either hangry or distracted. So we know that the impacts, across people in the lifespan are very consistent, are very significant. So we link our members with the program. It can be challenging to link to these programs in the community because Medicaid historically hasn't paid for them. But as funding becomes more scarce and we get better, we health plans get better at making these connections and referrals, the demand will go up. And then resources, will either stay the same or possibly decrease. These partnerships in the communities and communicating are key to identifying ways to scale up the innovative programs that improve outcomes for our members. And I do sound like a broken record often, but innovation doesn't always mean like bedazzled and super fancy and complicated. The innovation could actually just be very practical and pragmatic approach to ensuring that we are helping people maintain the housing that they have, whether that be for people with disabilities and older adults. It could be the community first choice option, money follows the person, ensuring that we're maintaining through home modifications even housing that people currently have, or helping to find new, affordable, and accessible housing. Working with advocates and experts who've collaborated on these studies to identify best practices that lead to improved outcomes, and we then work to include them in our plans across the country. Although healthcare is local, housing is local, jobs are local, finding food is local, there are food deserts, in certain areas. So whatever we do to scale, it's really around the infrastructure, and the rest we have to build very locally. We know that, affordable housing influences the health of people of all ages. It is an incredibly important strategy to support and improve well-being. These improvements can be documented across the spectrum for people with mental health, acute and chronic physical health conditions, and just overall satisfaction and quality from increased independence in people's living situations. We know that employment increases health status. Many states in their current RFPs and waivers are looking to include employment outcomes for people. And then what goes with that also is rebalancing funding to ensure that we are supporting employment support as robustly as we do day, have, and sheltered work, so we can get people back to work and help them maintain that. We look at developing, medical respite models for members who have to forego an elective procedure, like a colonoscopy maybe, because they don't have places to recuperate, or even do the prep work that goes with those. Creating short-term housing solutions that assist people with mental health or substance use disorders who might also be experiencing a housing crisis to provide respite and stability while they work with housing navigators to identify more permanent housing. We also, of course, through the Home and Community-Based Services regulation, are ensuring that we are looking at unbundling provider-owned housing and ensuring that we can break those conflicts, ensure the conflict of interest free, break the conflict of interest to people who require housing and services and that they're not tied together. States are working to find ways to tap federal Medicaid dollars to help people who are chronically homeless to stay in apartments. Medicaid doesn't pay necessarily for rent or building new housing, but it does reimburse nonprofits, as do health plans, to support formerly homeless people at daily tasks and adapt to housing. So there are a lot of ways that we can wrap around some of the challenges and barriers that may exist within Medicaid. And I think we do, our best work when we really are looking at partnerships and communication so we can continue to identify ways to move forward. So critical success factors, I see on here. I mean, we have assessment tools, in terms of getting to, better know and understand our members, creating individualized person-centered service plans, care coordination, care management, partnering with those community-based organizations to deliver those services and supports. And it's not just social supports, it's healthcare services as well, lifelines for people, peer support and communication, and community engagement. But honestly, none of this is really worth a hoot if we haven't engaged the member in this, and that really starts at the beginning, that discovery process of getting to know who our members are, being respectful. We heard it from our first speaker. I mean, we really, microabrasions, and, we make judgments on people sometimes by our body language and our responses to them. So really being very respectful and non-judgmental as we get to know our members, and then really being able to be creative, investing in people in their communities, working with, our members, their families, and the people they select to be part of their team, and hear from them. So including our members in this approach is critical. It's the only way to go to ensure that we can build the opportunities, innovations, or solutions that actually make sense to and for the people who use them, which leads me always to person-centered thinking and planning. So engaging members at the beginning, like I said, learning about them, what works for them, what's important not only for them, but what's important to them. That's the crux to actually really engaging people in self-ownership and self-care. So that way we can lead their plan of care based on those elements with them. So we spend a great deal of time, what I call not medicalizing people's lives, and that leads to the core discussions here on real life issues for real people. We can't have these conversations around person-centered thinking and planning and social determinants without talking about self-direction and people having control over their lives, their own health care. It's extremely empowering for any person of any age with any chronic health condition or disability or is aging. So we do find that self-direction really leads to a decreased turnover in direct support workers, which increases health outcomes, decreases acute crises, increases satisfaction with the Medicaid programs as well as their insurers and their community interactions, and also decreases risk for injury and for the workforce shortages that we see around as well. We do see it as a cornerstone of sustainable long-term service and support programs. People who are supported to direct their lives are happier and healthier, and people who can pick and choose the services that are important and meaningful to them not only have increased health outcomes, but they use fewer services. So people's lives, you know, again, it's what's important to them, not just for them. It's a critical distinction in engaging people in their health care and services. So here's my new favorite slide, the iceberg, but really understanding, you know, what's beneath the surface, what are all those social determinants. We talk about housing, employment, and community inclusion as, you know, being as critical and important to a person's health as traditional health care and services. And then being able to self-direct those services has that proven track record, again, of addressing many of these, you know, values and beliefs and the assumptions that we make because people are navigating that. When we talk about housing, community inclusion, those social support networks, those social environments, the culture, these pieces are incredibly valuable to a person because when we think about it, loneliness kills more people than heart disease. So if we're really just addressing healthcare and we're not addressing people having access to food and housing and employment and peer support and just peers in general having as many non-paid people in their lives, not just paid people, then we're actually leaving people without probably the support that they need. So we're not helping people if we're not supporting them in addressing the social determinants. And lastly, of course, when we look at lessons learned, none of this works if we're not engaging the individuals we support and their families, the advocacy community. These are just a few of the organizations we work with that try to pick a smattering of, you know, people that support employment, housing, people with intellectual and developmental disabilities, people with mental health and substance use disorders, people with physical disabilities, children, youth, and young adults in foster care, and then the other partners here are state partners. We've been very fortunate in having, you know, good supportive relationships with open, you know, state partners to ensure we can best meet the needs of individual health outcomes, state population, and overall health outcomes. So I think I actually even did that as quick as I could within the time allotted. I usually go over, but thank you again for the opportunity.